start first with Karen Creed, who is our lead midwife. So, Karen, you just want to say hello, please?
Hello, everyone. So, yeah, I'm lead midwife. I've been in post just over 6 months. And yeah, if any midwives want to get in touch with me, please do. I'm happy to come and speak to any of you. Thanks.
Thank you. And then Donna Gillen.
Hi, everybody. I'm in a really busy office, so I'm going to stay on mute unless I'm talking. I hope it's not too noisy. Yep, I'm one of the lead nurses for the GMSA. I'm based here at the QE for UHB in Birmingham, but we cover the whole of the region. And then obviously we've got Phil down on the South Coast. My background is as a cancer nurse, but as we all know, and as we're going to see today, genomics goes right the way through the whole of healthcare. So looking forward to seeing what your comments are today. And I've got a few very unusual and random questions for you. So let's have a good morning.
And then Phil, who is also nursing and midwifery team.
Hi, I'm Phil Costello. I am one of the nurses. I'm based down in Southampton. Really excited to be sharing with you this information today, and thank you to everybody that's going to be speaking. I'm also going to apologize in advance. I'm doing the technical side of this here, so hopefully all the slides and everything work well.
And just so that everyone knows, Phil has had a bit of a major disaster. They had a massive storm down in Southampton and she's lost part of her roof. So she's actually also got people around doing re-roofing. So yeah, there's a lot happening in Phil's life. So without any further ado, Sue, I believe you have joined us. So we're very fortunate today. Sue Hill, who is the Chief Scientific Officer for NHS England, has very kindly said that she will be joining us, and she's actually in Sweden, so we're really, really grateful to her for joining us today. Sue, thank you. It's lovely to see you, and I hope everything's going well at your meeting in Sweden.
Yeah, thank you very much, and hopefully you can hear me. I'm not going to use any slides this morning. I just want to give a big shout out though to the team, to Charlotte and everyone else who's going to be presenting today, and for all the work that you're doing across the GMSA footprint. There's no doubt about it that genomic medicine is really accelerating at pace wherever we are in the world, and this conference here in Sweden is all about genomics and precision medicine. And so what we know is that we have the technology now and the analytical capability to really analyze all the 3 billion letters in a human genome, but also the genomic makeup of tumours to help us better inform treatments for diagnoses and treatments for patients, but also to think beyond treating an individual as an N equals 1, although that's really important when we get to some of the personalised treatments and interventions. But in terms of the genomic diagnostics that we're applying, so whether it's whole genome sequencing or other types of, not looking at the whole genome but parts of it, we know that we can improve the outcome for patients if we look across not only the UK, well, England and the UK, but if we look across the world, because sometimes in the case of rare and inherited disease, there may be only a small number of cases across the world. But from the NHS Genomic Medicine Service, we have the infrastructure in place now, the genomic laboratory hubs, the 7 genomic medicine service alliances, the 17 clinical genomic services. We have a genomics education programme. We have a way of working with other specialties, and we're about to create 25 cellular pathology genomic centres to improve the pathway from acquisition of cancer tissue, wherever that might be, into genomic testing. So the infrastructure is coming together. What we do need to do, though, is to make sure that the whole of the multi-professional team is engaged, because genomics covers the whole of the life course. And indeed, it's being applied in an in utero setting for a raft of different prenatal testing, and looking at fetal testing, really understanding whether pregnancies should be terminated or continued, and indeed whether pregnancies that have not that resulted in a healthy baby, what is associated with demise of that fetus, right through to looking at applications in newborns, through the whole life course of in rare disease, where we know that about 30% of patients with rare disease don't actually get a diagnosis. A large number of children under the age of 5 die from their rare and disease. And if you take that number across the whole world, it means that there are about 60 million children under the age of 5 dying each year. So part of our challenge is how do we get better treatments for those, but right through as we come into childhood cancers, into adulthood with some of the inherited conditions, into cancers, for example, right through now with some of the work that we'll be doing in dementia and Alzheimer's, and in obesity. So it really is covering the whole lifespan. We are world leading in terms of our genomic medicine service, and I'll be talking about that here in Sweden tomorrow. But the diagnosis is important, and in rare disease we've got to drive more treatable rare disease, more work with industry on drug discovery, but also how we can start to bring sort of some of those individualized gene therapies to patients quicker, so we get a better outcome. That's particularly in children, for example. But in cancer, how do we make sure that we can deliver what will be a nationally agreed turnaround time from acquisition of cancer tissue through to getting a genomic result of less than 7 days for urgent cases, less than 14 days for routine, for access to large panel testing, which will have all the actionable targets for precision medicine, such as in lung cancer. And there are about 27 licensed precision medicines at the moment, right through to clinical trial targets that enable people to enter clinical trials. And then around 21 to 28 days for the rest, and that covers hematological malignancy and solid tumours. So to make this work, it won't work without nurses and midwives. And indeed, as we move into the newborn screening, whole genome sequencing screening programme, we'll need the involvement of health visitors as well. So this plea today is to say we've got the tools and techniques to help nurses and midwives make a real contribution, to understand where you fit in the overall pathway, supported by education and training. But what needs to link with this is changes in clinical practice and standard operating procedures, and all the things that nurses and midwives are really fantastic at doing in terms of practice. So I thank you all for coming. I thank the leaders we need advocates in this part of the workforce. Thank you for all coming together today. And we can't achieve this for our patients, their families, and the population at large, which is where we're heading as well with genomics, unless we have nurses and midwives. You're the advocates, you're the people who actually see the patients the most in the system, and therefore we need you to be a key partner, whilst we also get our laboratories to be the best they can be in the world, and our clinicians also suitably informed. But we're a team and we have to work together as a team, and I recognise all of your contributions, so thank you very much. Thank you, Charlotte.
Thank you very much for that, Sue. Really appreciate you taking your time out. And it's actually always very inspiring listening to you, because you're always so passionate about what genomics is going to be doing for us and is already doing for us as a population. We've all got some really enthusiastic and dynamic people who are going to be speaking to you about different areas. One of the things I would also say is that our plans are, we're going to be continuing with a further 2 webinars in this series, but we're also going to be starting to have not only multi-professional webinars, but we're also going to be including our colleagues from other GMSAs to share what they've managed to do and have achieved. So it's great that we've got your support, Sue. Thank you very much.
Great, thank you. Have a great webinar.
Thank you,
everyone. Bye.
Bye. And what I've managed to do, which I'm really pleased about, is that I did not go straight for touching leave as I said goodbye, which is normally what I do. So everybody, Donna, are you going to introduce the next speakers?
I can do. I think we've got a bit of time, haven't we, before the next
does
speakers?
that mean that we've got a little bit of time just for you to ask some questions?
Yeah, so I've got some what might seem a bit random questions. They're a bit of fun, really. So, but just we're not making any assumptions of what about your backgrounds out there, because obviously we've got a wide variety, and the purpose was to invite people along who don't really know an awful lot about genomics. But I appreciate that some of you are probably working with genomics and know a huge amount, probably more than me. So just take this as a little bit of fun. And what I'm going to do is just share a slide with a question, and then if you want to put a comment in the chat, that would be great. We know that you're live out there and breathing, and then we can just have a little bit of a chat about the obvious answer. So let me see if I can pop that first one up. Bear with me a second. I think I'm the technophobe here. So
okay.
Look. Is that sharing?
Yes, it is. Thank you, Donna. So if people want to put answers in the chat, and we will tell you that some of these have come from a game which is called the Genomics game, and some questions from that can seem like they are a little bit too easy, but then it will suddenly throw you with a very complex question, like indeed this one is. But we encourage people to take them round and also share them with students, with our schools, because we do go out to schools as well, and it's really great for them to do it. So answers in the chat, please. I expect to have.
They're doing well, Charlotte. They're doing really well. Thank you so much for taking part.
That's good, because
I haven't got an A yet. I'm waiting for an A. 18 months ago, I'd have put A.
I'm not going to say.
No,
I'm not going to say
no,
what I'm going to put, but you know, I need to go on to anonymous first. So thank you to those that are participating. That's really good.
So I think it's fair to move on with this one.
I think so.
As you have correctly identified, DNA is not an explosive, and DNA is not a molecule that carries oxygen. It is actually what carries our genetic DNA. It's the instructions that keep us well. And we'll go, obviously, we'll go into more detail about all this as we move through. So well done with that one. I have an equally, can I do one more? And
you can indeed.
Yeah. Okay, so the next one is equally as difficult as that one, so bear with us. And the next one is, what is a genome? Is a genome in your garden? Have you got any little genomes running around in your garden? Or is it an organism, complete genetic material? Or is it an individual gene? Any answers out there? Answers not on a postcard, answers in the chat, if you will. Thank you very much. Oh, we do. Well spotted. You get an extra prize if we had any. You're quite right. That's because I just put these slides together in about 2 minutes flat this morning. So C is actually the second A.
Oh, it is. And that's
Yeah.
what we were testing for. So well done, Donna.
Well
for
done picking that
encouraging
up.
people
Well
to do
done
that.
picking that up. Yeah. That was just a little extra test in there, little extra test. Okay, so we've got a mixture of replies coming through there. So we have a combination. I think most people know that it's not a garden ornament, so well done on that one. But we do actually have a combination of B and the second A or the C, which is an organism's complete genetic material or an individual gene. So the main difference for when we talk about genomics and we talk about the genome is we're not just talking about individual genes. When we talk about individual genes, we're more likely to be talking about genetics and about inheritance. Genomics deals with, and the genome deals with the whole genetic material of an organism, and it covers a huge area of healthcare, which is why we're making a big effort now to reach out to the workforce and educate about it, because it is about disease, and that's what we're here to talk about, and it is about recognizing it and being able to diagnose and predict and try and avoid disease and treat it appropriately. And precision medicine, it is all of those things. But also, if we're just looking at the genome, a lot of what goes on in the genome is completely normal. And that's the genome's role is to keep us well and functioning and living a healthy life. So thank you for taking part. That's really good. Should we save some questions for a bit further along, or who have we got coming up next?
We've got
Victoria's next.
Victoria, are you on the call? Are you ready? Do you want to go ahead, or otherwise maybe we could potentially put another question in, Donna?
Hiya, I'm ready. If you don't,
ready.
hello.
Victoria.
Hello.
Sorry, mad dash back. There was me in another room taking a call. I'm happy to make a start now, or equally leave you alone to do another question. Which would you rather?
Well, if you're here, that would be great, wouldn't it? I think.
Yeah.
So can I introduce Victoria, who's very kindly come from the charity Oakham. There she is. Hello there. They're a charity that work with people with ovarian cancer. And as some of you may know, ovarian cancer can be linked very closely to breast and prostate cancer via the BRCA gene. Victoria is an expert and has very kindly, because of her knowledge and because of the way that the charity reaches out to the communities and work with people who've been touched by this disease, that she's a very good person to come along and talk about EDI, or equality, diversity and inclusion, which we are hoping is going to run through everything that we do as a GMSA. So thank you very much, Victoria. Lovely to see you.
Hi, Donna. Thank you. That was the loveliest introduction I think I've had for a very long time, actually. So thank you very much. Can everybody hear me okay? Sound okay? Can you all see my screen?
Yes.
Okay. So we've tried to make this presentation a little specific relating to genomics, but I think we could probably talk for hours about genomics and EDI. So, you know, given that we've got sort of 10-15 minutes, I'm just going to touch on some of the points that are a bit more general around equality, diversity and inclusion. And then if anybody has any questions, please do come back. We're ever such an approachable bunch, and we do love hearing from you. And there are some people on this call, because I've just looked at participants who we've actually done joint projects with in the past that we've really enjoyed. So we are always open to doing that. So Overcome is the ovarian cancer support charity for the UK. And now I need to try and get my slides to move. There we go. Here we are. We're a community for those affected by ovarian cancer. We're a bit weird, because we're not just a charity that exists to serve a purpose. We're a charity that exists to serve the changing needs of our community. And what that means to us is that we are well represented by service users on our board, and we're a membership charity. So that means that it's free to become a member. You don't have to become a member to access our services, but if you are a member, you can request specific services from us. And because of that, we are obligated to be representative of the population that we potentially could be supporting. So each year we support around, well, over 6,000 people. That's with direct support contacts. And actually, we supply around 250,000 people with further information as well. We have an online forum that's 24/7, and we have over 16,000 members on that, and all of our services are free. So we exist to support anybody affected by ovarian cancer. And that includes you as clinicians, if you're working with people affected by ovarian cancer. Right, so within ovarian cancer, what do we actually know with regards to health inequalities? We know that not everybody's experience of cancer is equal. We know health inequalities are not only differences in certain groups of health status, but also the barriers experienced in being diagnosed and accessing treatment and support. We also know from so much research that those diagnosed with rare and less common cancers experience inequality because of their tumour type. Now, if that intersects with protected characteristics such as age, disability, neurodiversity, gender, sexuality, or ethnicity or religion, beliefs, then actually we know that those patients are particularly disadvantaged and or isolated, and they face a lot of additional barriers. So this is what we're talking about when we talk about intersectionality, and the fact that actually one barrier is a problem, multiple barriers can be a real issue, and it really can prevent patients from getting the diagnosis in a timely way. It can prevent the patients from getting the treatment options or understanding the treatment options effectively, and also it can impact on them being able to access support from organisations such as ours or from you as well. So one stat just relating to ovarian cancer, and there are stats for if we were going broader than ovarian cancer, I'd be able to supply you with millions. But basically, we know that survival rates from ovarian cancer in the UK could be improved by 45% if all patients were treated in specialised centres. That tells us a great deal about how we manage the diagnostic pathway, the treatment pathway, and the support for patients, particularly those in rurally isolated areas or away from major centres. And this is in no way intended to be a criticism of the system as it is, or the clinicians that are treating people with fewer or more resources. This is essentially just an opportunity for us to highlight the patient perspective. So within ovarian cancer, in 2018, we undertook an extensive mapping and gapping. We knew that there were some groups who were underserved and who were facing barriers to accessing diagnosis, treatment and support. We knew that anecdotally, and we knew it because we could tap into some research. So what we then did was we looked at our membership and the people accessing our services. And we said, what would our population look like? What would our membership look like if it was representative of the UK population and those who should be or could be accessing our services? And we discovered that we were failing a great number of our members or our potential beneficiaries, because essentially our service users were pretty monocultural. They were white, middle class, between the ages of 55 and 65, had been educated well, were not suffering from any income deprivation, or, they were able basically to navigate the system. So from 2018 until this date, we have set about trying to address that. And what we have learned, the lessons we have learned, and the co-production model that we've used means that we've been able to work with a great many NHS trusts also to help you address some of the issues that you see amongst your patients. So within ovarian cancer, these are the groups that we know who are underserved or who face barriers to accessing diagnosis, treatment or support. So ethnic groups other than white, people who are LGBTQ plus IA, under 45s, over 75s, those who are rurally isolated, those who are digitally excluded, people with English as a second language, those on a low income, people with low levels of health literacy, Gypsy, Roma, traveller, showman and boatman communities, people with disabilities other than cancer, and refugees and asylum seekers. Now, the interesting thing for us was, once we'd completed our mapping and gapping exercise, once we'd set up focus groups, once we'd started to work with community groups and grassroots organisations to really understand the lived experience of these patients and their families, family members and friends and carers, what we actually came to understand was all of these groups, statistically, if we collected all of them together, they make up the majority of ovarian cancer patients, which for us makes a very strong and compelling argument towards not just personalised care, but actually understanding the lived experience and challenging ourselves to do better with regards to reducing barriers to accessing our services, but also working with NHS trusts so that you can do the same when it comes to people affected by ovarian cancer. So there's a big old list there, quite daunting, and we're working with each one of these groups and a number of other charities. So we've got Della here. I'm really hoping that this plays properly. Della's one of our members, and she's just explaining to us about BRCA, so the BRCA mutation in ovarian cancer, also linked to breast cancer, for example, and her perspective of that. I really hope that you're going to be able to hear this. Give me a shout if you can't.
Oh, another thing that happened to me is I now discovered I am a BRCA2 gene, and I'm like, hey, what's that all about? And when I want to talk to people in my community, I say, you know what Angela Jody had? Because I don't know a Black person that says BRCA2. I don't know what BRCA2 is. And this is what nobody explains to me. I'm a Black woman. Maybe a white woman knows everything about BRCA2, gene mut, da, 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 da. That's another thing. That's not telling me what it's all about. Now I know what it means. You know, it's just explaining those words. Like for a Black person, what's that? And everything is a white man's disease because nobody explains it to us. I was talking to a friend yesterday, and the story she told me was sometimes.
Oh, sorry. Is that working, Donna?
It was working. It just came to an abrupt stop then.
That's fab. I think it was just where we had people joining the call and it just kind of made it bounce. I'm just going to finish this last clip from Della, just because it's really powerful and I think it helps us all to understand.
About genomics, and I was hoping I would be able to join.
Yesterday,
hold on.
And the story she told me was sometimes they don't know how to talk to us. They find us aggressive. I'm like, excuse me. Maybe they need to sit down with Black people, and this is how we talk. We're not aggressive. I don't know, role play. Let's bridge this gap. Maybe then we'll both win, because now if you go in, the first thing, oh, because I'm Black. It's not because you're Black. It's just you don't know how to talk to a Black person. I would say it's quite difficult going in to explain.
Oh, thank you. Sorry about that, people. The Della has a lot of clips. We've worked with Della a lot, and she has got some very strong and very clear opinions, and they are very, very wonderful. She is a great community ambassador. So I think that brings us back. When we've done co-production work with some of the organisations, they've told us that actually it's not acceptable really just to explain things within a clinical setting and not check back in. Now, I know that because we've got CNSs on the call and we've got midwives on the call and we've got AHPs on the call, that actually that's the work that you guys do, and it's wonderful that you do that. And I know that actually our members are very well served by you know, people doing your jobs, but I also know that sometimes they come out of other appointments and they come out of appointments very, very confused. And I think it speaks to that point where actually it's about us all just checking back in and saying, have we explained this in a way that you can understand that is relevant to you? You can always signpost people to our services. You know, we have really well-trained, really qualified staff who are able to unpick cultural sensitivities, understand language barriers, and work around some of those issues. I've just left this up here, just a quote from somebody who is non-binary, actually trans, with ovaries, who had a family history of cancer. In recent years, we've moved into using non-gendered language, even though we are essentially an ovarian cancer support charity. And that has had some backlash for us, but it has meant that actually we've seen a huge diversity in membership and people able to access our services. And that is really important, because for some people, particularly trans people or LGBT, they are experiencing huge amounts of stigma and huge difficulties you know, and accessing local primary care. You know, there are huge issues within their communities with regards to trust. So I think it is, you know, it's really important to us as a charity that we use non-gendered language and, you know, diversify our imagery as well. But this quote really just tells us about sometimes when we get it right, it can be massively gratifying. I don't think we've got time to do low income, and I'm sure that you would all be very aware of patients on a low income.
Lindy hasn't worked since her ovarian.
So skipping through to English as a second language, I guess for some of you, you'll have patients who have English as a second language. I think one of the things that we hear consistently is that quite often patients go in to appointments, and as Samiksa's quote here identifies, oh, just talk to my son or my daughter. And actually, quite often for patients, sometimes elderly ladies who have English as a second language, if their son or their daughter is interpreting for them and they don't have an interpreter or the opportunity to explore issues independently of a family member, we really aren't giving them the information that they need. We really aren't giving them the opportunity to ask questions. You know, it's a very, you know, we have community language lines in 8 different languages, and we can provide interpreters in 250 languages at Overcome. And one of the things that's really a recurring theme for us is on an almost weekly basis, we will hear from people who said, I went to an appointment with my son or my brother or my husband. They were interpreting for me because there was not an interpreter available, or because there was an assumption made that that interpreter, you know, that would be best. And so I was not able to ask about sexual function. I was not able to ask about my feelings about returning to sexual relationship. I was not able to ask about whether or not my bowel movements are normal. And those sorts of calls really are, you know, it's a recurring theme for us on our support lines. So.
Thank you so much, Victoria. That was really a good oversight, I think, of all of the issues that relate to every area that people out there are working in, as well as ovarian cancer. We've got one question that's coming from Hilary, who I know is a gynecology CNS, and she's asking about the sample size of the research that you started with. I don't know whether you could tell us a little bit more about that.
Yeah, so the mapping and gapping exercise that we undertook in 2018, we looked at our sample size of people who identified through basically becoming members of or attending events that we were organising, and how they identified and how they kind of self-identified their protected characteristics. And then we looked at the representative number that we should have been servicing if we were looking at the UK population, so potential population using the statistics at the time of those who potentially would have been diagnosed with ovarian cancer. And that was our comparator point. It wasn't a piece of research that we actually published. It was an internal mapping and gapping exercise for us to understand whether or not we were meeting the needs of a diverse population. And it identified for us that we really weren't, and we were failing so many people. That really, actually, when it comes to ovarian cancer, we need to really think about some niche services that might only be they may only ever be accessed by a very small number of people. You know, the trans work that we do, we regularly just see just a small handful of people who are transitioning or who are trans from the trans community coming to us. But actually, we are providing services to them that are exponentially more useful, you know, and more tailored to their needs, that really give them the opportunity to self-advocate. Likewise with some of the much smaller ethnic minorities, for example, like the Roma community or the traveller community. So I suppose, yeah, it was. So what we did, Hilary, was it was a comparison. It was a comparison. It wasn't a piece of research. It was a comparative study that we did internally. We've got another question.
So that one is patients with substance misuse, alcohol or drugs would definitely come under an underserved group for many reasons, some of which are on your list already. Do you ever see this group of patients?
So we support lots of people who have substance misuse issues. Sometimes we through our support services identify that very clearly. Sometimes people come and identify that to us and say, I have this addiction issue and I'm not able to talk to my clinical team about it, or I have this, what impact it's going to have on my treatment and so on. We always, we don't have anybody's medical notes. We don't give advice about treatment, but what we would do is we would give them strategies for being able to broach that subject and that topic with you guys, you experts. And we strongly encourage them. We do kind of follow-up calls. We would consider them, for whoever it was that asked this question, we would consider those people, so people with substance misuse issues, particularly if there are entrenched addiction issues or there are kind of dual diagnoses with mental health problems, which very often we know there are, to come into the people who have disabilities other than ovarian cancer directly. And so within that, our support team certainly have additional training to work with those people on support services. And we do see a significant amount more people from that category contacting our support lines or our support services with safeguarding issues, and us having to escalate it outside of our services into emergency mental health teams, we have, very strong safeguarding processes in place, because we have had to alert police, we have had to, do all sorts of things. It's a fairly regular occurrences for us. And they are nearly always people that have been diagnosed with ovarian cancer who are, at a particularly difficult point in their treatment, but always they have compounding issues such as alcohol, substance misuse, drug dependency, dual diagnosis with mental illness.
I think that's quite significant that they reach out to yourselves for support, isn't it? And I think it also sort of illustrates how the charity sector has become a really important and essential part of the NHS care that we give. That's a really good illustration, I think. Are there any more questions out there from people? Any comments?
So I have a question, Victoria. Thank you very much. I love listening to you. But just thinking about the English and the use of interpreters, and actually going back to Della's point and saying, what are these words? What do they mean? Do you work with interpreting services in terms of like the way they speaking and how they interpreting? Because if you're just going to interpret what the clinician is saying, you still have the same issues, isn't it? So
Absolutely.
what work do you do with the interpreters as well? Because I think that's a concern of mine when I'm talking to patients. If I am trying to explain and I have an interpreter, I'm always worried, like, there's no difference in the information that's coming through, and actually is it making it worse in the language I'm using and trying to adjust my language?
Yeah, I mean, it's hugely difficult, Phil. I would say my last job, the one pre-Overcome, I actually worked in East Africa, and we used to translate and interpret. We had interpreters that would go into 80 different languages, because Ethiopia is incredibly diverse, and Sudan, Somalia. And it was a constant theme was actually, are these people properly consenting to treatment? Are these patients properly consenting to treatment? Do they understand the implications? And I've seen a similar theme, somewhat less complex, in the UK, but there is a similar theme. So what we try and do on our support lines is we always say, so we'll be asked a question, interpreter will interpret that question for us, and our staff are trained to say it back in a slightly different way in terms of, do I understand that your question is, and kind of drill down to the original point. And then that enables the person who has English as a second language to actually reflect, was that a true interpretation? Are we giving them the answer to the question that they actually asked, or the interpreter's interpretation of the question that they actually asked? I mean, the interpreter services that we use, we contract specifically because we have done training with those interpreters to understand and not to misinterpret. So in some of the language they interpret into, that they're translating into, even with BSL, for example, it's very difficult because in some of those languages, there's no word for ovary. So there is no word for ovary. It does not exist. So actually, in that sense, we've already got a bit of a mountain to climb in terms of helping people understand. So we use imagery. And using imagery to support a translated or interpreted resource or contact with people who are accessing our services is nearly always the best way to ensure that somebody can, you know, is accessing it or understanding it in the best possible way. And then so yeah, it's really difficult. I mean, I guess what we would always try and do, Phil, is, but again, we're in a weird way, as a small charity, we are in a much more privileged position than you in terms of our interpreter services, because we can specify, you know, no interpreters are coming on this call unless they've seen our slides, unless they've seen how we do this. You know, we're not paying you to deliver this service to us. We're not contracting this from you unless your interpreters are seasoned or able to understand that it's not their interpretation of the question that we want. So sometimes it will take longer, and we allow a lot of extra time for our interpreted calls or translated, you know, resources. But, you know, we do feel that that's getting us further forwards with patients themselves.
That's really great. And that's just such an important point, isn't it, about interpretation and using imagery, but also the fact that you have got that luxury, that benefits of working with the interpreters. And I think for us as nurses or as healthcare professionals, it's also, before we start booking an interpreter, is also maybe having those conversations beforehand, before you speaking with the patient, just to make sure the interpreter also understands what you're trying to get across as well.
Yeah.
So thank you very much. But I see Kafila has a question, and we are ahead of time. So Kafila, go ahead.
Hi, thank you. Hi, sorry. I'll just put my camera on so you can see me. Hi, it's Kafila here. I'm an engagement lead for Macmillan. Great presentation, Victoria. Honestly, I think it's health inequalities is so complex, and the way that you've just presented that and really highlighted those key points. So at Macmillan, you know, we've got the same sort of objectives around health inequalities, trying to reduce health inequalities, working with that cohort that you've also mentioned. Similarly, you know, looking at other groups that we're not reaching at the moment that might not be within that at the moment. So a couple of questions really. You mentioned about, you know, the gapping exercise that the mapping gapping exercise that you did. Just, you know, be keen to know a little bit more about, you know, how you sort of targeted those individuals and how you drew that data. And then the other question really to find out from you is, you know, this is fantastic work. It's amazing. It's very much needed. What sort of mechanisms have you got to try and influence, like you said, the partners that we've got out there, the providers that are working with individuals from marginalised communities that might not be aware of the access barriers?
Wow, Phila, you and I should probably have a meeting separately. I'll drop my contact details in. So the first question was sort of how did we identify those, you know, who we, or how did we kind of identify those people who we were not serving effectively, right? That was the first question. Was that the first question?
Yes, yeah.
And that was, do you know what? We had to start from real scratch. In 2017, when I arrived, and I said, when somebody signs up to become a member of Overcome or when they attend an event, what information do we request from them? And everybody looked at me blankly, and I was like, well, how do we know whether or not we're providing to a potential population if we don't ask the right questions? We had to start from the absolute basics, like, do they identify as a heterosexual woman? You know, all sorts of, you know, bazillions of questions, like really core questions, so that we had a baseline to measure from. So essentially we do have a membership, and because we have a membership, we are able to basically look at that on our CRM and go, right, okay, who identifies as this and who identifies as this? The interesting thing for us is we're also able to measure that now. Okay, so we can look at where we were back in 2018 when we started asking the questions with people who were members, and we can look at now and we can say how much more diverse is our community. And interestingly, people of colour, so non-white people, we've seen an increase of 380%, so nearly fourfold of people of colour becoming members and accessing our services. And also likewise, people with English as a second language, people don't have to be a member to access our services, but what we have seen is we've seen a significant increase in the numbers of people requesting interpreters or translations of our information, including BSL, you know, so we also provide BSL interpreters. So that enables us to manage growth and diversity within our community from our very basic baseline. So that's I hope that kind of helps answer that question. And then Kafila, we do loads of co-production work. One of the roots, the foundations of the way that we choose to work at Overcome, one of the ways that we can work, because we are a charity, as long as we can secure the funding, which we've been quite successful at, we are able to co-produce with community groups. So we have projects running along with each of those marginalized or underrepresented or underserved populations. We have, for example, we have a staff member who's working really in depth with showmen and boatmen, Roma communities, travelers, to look at their health needs, not just around ovarian cancer treatment, but actually about barriers to diagnosis. So if they're not receiving Public Health England's campaign messaging, how can we provide that in a way that is accessible? How can we use language that is culturally appropriate to them? So for each of our groups, we've got a co-production piece of work happening. And what that does for us, what that does for me on a daily basis, is reminds me of how little we know and how far we are away from where we'd like to be. I guess progress, not perfection, right? But nevertheless, every time we do some of this work, it's like, oh God, why didn't we think of that? Why isn't this happening like this? But I think there's a willingness from us anyway to work with any NHS trusts that want to engage with us. It's really hard because we're talking about such a diverse group. So I think that, if anybody has any follow-up questions that are specific to your work, to your patients, do feel free to get in touch, because we have loads of other kind of more specialist and targeted training, support or information or meetings that we can set up, resources that we can share. So yeah, obviously we'd love to do the whole of this meeting, but I know you've got other speakers. Sorry, Phil. Sorry, Charlotte.
Thank you so much. It's always so it's so wonderful to listen to you and the work you're doing, and such important work. And hopefully for those that have joined the call, it's just thinking, keep it at the top of your minds as well when you're talking to your patients, and thinking about the whole range of issues that a patient has, never mind understanding genetic testing or genomic testing. It's all those other little bits in between as well. Thank you so much. Thank you very much, Victoria.
Thank you, Victoria.
We are just to interrupt, Victoria, I have put something in the chat saying that we are going to be in touch with you, because Phil and I are working on our own EDI strategy at the moment, and it would be great to do some work with you as well. We're making massive progress at the moment, so I think there's a lot we can do together. And also, just so you know, we do work closely with Kafila as well, who's amazing in the Midlands.
Yeah.
So
I've dropped my email. Please, if anybody wants to, just ping me an email, just run anything past me or just pick anything up from the call. I'm really, really happy to do that. Kafila, thank you very much. I've also got yours now. That's lovely. Okay, I'm going to leave you to it. Thank you very much. Cheers.
Thank you very much. Well, we could talk about that all day, but we won't. The next speaker we have is Georgiana, who is one of our nurses. And if I can leave you to introduce yourself whilst I just try to attempt to share my screen so I can get your slides up, if that's okay. And hopefully this is going to work.
Great. Thank you. I've sent you a second set of slides this morning. Okay.
Yeah. So I'm hoping that's going to come up now. Give me 2 ticks with my technical non-ability at the moment.
That's okay. So whilst you do that, let me just introduce myself. So hello everyone, my name is Georgiana. I work as an advanced nurse practitioner in inherited cardiac conditions at University Hospitals Birmingham. And then I also work on a very exciting and special project with the Central and South Genomic Medicine Alliance. And I will talk about that project in my slide today. So the title of my slide, Nursing with a Twist. The twist probably gives it away with the first page there. So how do I ensure that I embed genomics in my everyday practice? And why do I think it's important to always have genomics at the back of our mind? So I don't think I can, okay. All right, so why is genomics important to me? And these two pictures, I believe, sums it up pretty well. So I work with those who had been fortunate enough to survive an out-of-hospital cardiac arrest. But I also work with the family of those who sadly have not been that fortunate and have passed away from sudden cardiac death. And as you can see, the numbers are quite high. In the UK, every year we lose about 300 people to cardiac arrest. As you know, the chances of survival of an out-of-hospital cardiac arrest are about only 10%, which means the vast majority of the 374 people affected by a cardiac arrest actually do die. A high proportion of those are youth under the age of 18, and very sadly in the UK we lose about 12 young people to undiagnosed cardiac conditions. Next slide. Okay, so here I'm going to talk about some of the causes for sudden cardiac death. So as you can see, the vast majority of those are coronary artery disease, which largely do not have an inherited component, but there is a big proportion, about 20 to 25% of these deaths, which do have an inheritable component, and that's mainly arrhythmia syndromes. So these are caused by mutations in proteins involved in generating the action potential. So here we talk about syndromes such as long QT syndrome, short QT syndrome, Brugada syndrome, or CPVT. Then we have our cardiomyopathies. And here we have hypertrophic cardiomyopathy, dilated cardiomyopathy, and arrhythmogenic cardiomyopathy. And again, these are caused by mutations in proteins making up the contractile system of the myofibrils. And then we have our inherited orthopathies. And these are conditions such as Marfan syndrome caused mainly by genetic alteration affecting the connective tissue. So as you can see, there is quite a bunch of conditions which can kill someone and do have an inherited component. So how can we work together to prevent this from happening to our patients? And next slide. Okay, so the way we are doing this now in England is through this very important work. It is a pilot. It's called the NHS and Coronial Sudden Unexpected Death Pilot. And what this is aiming to do is aiming to work together with the coronial system to identify those at risk of dying suddenly, especially when there's already been a sudden death in the family. So if we can move on to the next slide, I'll talk a little bit about the background of the project. Yeah, you can do the whole slide, Phil. Yeah. So nationally, we've seen a lot of inconsistency in the level of support that we provide to this patient group. Many of these family members, after the loved one passes away, they are left without any answers, and they don't realize that they themselves are also at risk of the same thing happening. So we then realized that there is a need to deliver a much more personalized medical management to these families, which is why a group of stakeholders in 2018, 2019 got together, but the pilot really took off in 2020 because of the pandemic. And they realized there is a need to deliver this this personalized medical management, which, if you click next, Phil, will encompass cardiac pathology. So that's the post-mortem of the heart, then post-mortem genetic testing, and then clinical evaluation of the family members who have survived. Next slide. So here on this slide, I'm just going to talk about our local team here with the Central and South GMSA. So as you can see, we have involvement from the senior coroner, we have coroner officers that we work closely with. We have involvement from the cardiology department, from the pathology department, the genetics, as well as the GLH in Birmingham, but also Oxford. And then on the right is just a wheel where I try to illustrate how the pathway really works. So when someone dies suddenly, the coroner is being alerted and they open a case and they will assign that case to a pathologist. They will ask a pathologist to carry out a post-mortem. The pathologist will do their post-mortem and they will realize that potentially this may be due to a cardiac cause. So at that point, they will retain some genetic material. They will retain some fresh tissue from that person. And the tissue normally is a little bit of a split sample. And then they will also take fresh blood, which they will then transfer to the Birmingham GLH. Now, it takes a bit of time for the final post-mortem to be put together. It takes about 4 to 6 months. But once we have that, then the case is signposted to this pilot. And that's when the genomic testing begins. And that's when also the cardiac evaluation of the surviving relative family members begins. Next slide. Okay, and here I'm just going to touch upon my role within this pilot. So I think it's important to mention that I don't work in isolation. So as I said, there is 7 of us. We call ourselves coordinators, and there is one linked to each GMSA region in England. And essentially what we do, we act as an expert practitioner, and we try to implement this pathway, providing leadership where it's needed. We try to improve the collaboration process between the coronial service and the NHS. Prior to this pilot, really, we didn't have a relationship with the coroner. So that was a major development that this pilot has brought forward. We facilitate the referrals of family members to an NHS dedicated cardiac service, which can look after them and their condition. We also facilitate genomic counselling and testing. We work to support the standardization of the post-mortem practice, just to ensure that everyone does the same thing. We all retain the same sample in the same way. We support coroners, pathologists and other colleagues with educational materials. We ensure that the tissue that's been retained by the pathologist actually makes its way safely to the GLH for storage and testing. And then we also do some data gathering to support the pilot level KPIs and the reporting to NHS England, but also the external evaluation of the pilot, as we are evaluated on an ongoing basis. And then to summarize, I'm just going to touch upon some of the results that we've had so far on the next slide. Okay, if you click on that's right. Okay, so we've had approximately 75 cases that have been signposted nationally. About 13, 14 of those have been in our region. There's been about 200 family members assessed in a dedicated inherited cardiac condition centre nationally. We've managed to link multiple coroners and NHS services across England. We've supported family members with the decision-making process on tissue retention, because this is a dilemma for many of the family members. They don't want their loved one after they have passed away to have a heart taken away and sent for later analysis. They don't always understand the importance of that, and they want to make sure when they bury the individual, everything is buried together. So there's a lot of talk that we have to do with family members to help them understand the importance of that. And then we signpost those who are at risk to services that perhaps are nationally. So let's say someone dies within our region, but their family members live all over the country. So we have to make sure that they are also looked after wherever they live. And then we've had a lot of improvement in terms of how we deliver this model. So a lot of this model is delivered in more or less of a one-stop shop type of appointment. Loads of these appointments are virtual, and those who are in person, we try and deliver everything in one visit to reduce the family inconvenience and the multiple visits to hospital. And then perhaps the most important thing is that a lot of this has been nurse-led. So the nurses are actually driving the project, although it involves many other healthcare professionals. We do a lot of the risk stratification, a lot of the counselling, we activate genomic testing, we deliver results, we ensure the family member is being investigated. So through this work, we've actually managed to build a lot of expertise amongst our nursing community and to increase the job satisfaction amongst our peers. And that's all from me today. Thank you very much. Any questions?
That was fascinating. Thank you so much, Georgiana. I've got one question while people are thinking, and that was just really around those conversations, because like you said, that's a really difficult time, isn't it, to be requesting to access your loved one's heart. Are there many families that just are very very upset by being asked? Would you get some quite negative reactions, as well as the people that maybe understand the benefits?
Yes, we do get some negative reactions. We also get some very hard no's. So people refuse, even despite multiple and comprehensive conversations with them. So we do get that quite a lot.
Mm-hmm.
And it's mainly helping the family understand that the heart will be reunited with the body, although at a later date, and making them understand the importance of that analysis and the fact that it's really a one-time only opportunity to look into the matter, and that once the heart is sent away, then that opportunity goes. So then we're not able to help the family after that. And then after having this conversation, I would say the vast majority of patients do realize the importance and they agree to go ahead. But then there is always that very small percentage which they refuse. And yeah, it is a choice that they have, and we have to accept that.
Yeah, of course, of course. And is it something that would be available in most trusts throughout the region now? I presume you need to have that infrastructure, that conversation with the coronial service in particular areas to be able to do
Correct.
that.
So we're only running this off the 7 GMSAs across England. So there are 7 trusts and 7 coroner jurisdictions attached to it. And this pilot runs for 2 years. We are in our 2nd year now, and the aim is that at the end of the pilot, we will roll this nationally in a gradual fashion, but we hope to incorporate more and more trusts and more coroner jurisdictions.
Brilliant. Excellent work. Thank you so much, Georgiana. Any questions or comments out there before we move on? Okay, thank you very much. Thank you. So our next speaker, I believe, is Laura. Is Laura?
Oh, sorry. We've got a video next.
Oh, okay. I've jumped ahead. Phil's in control.
Yeah, so we've got a video now from Kate Edridge, who is the systemic anti-cancer treatment clinical nurse specialist based here in Southampton. And hopefully this again is going to work. And Kate is just going to give an overview of her role and actually what education is out there. So I hope this is going to work. I'm just going to have to try this again. Seem to have issues going on. Right, here. Please let me know if you can't see.
I'm kindly invited to join your webinar today and provide a bit of an overview of why genomics is relevant in my practice. My name is Kate. I work in oncology as a systemic anti-cancer therapy clinical nurse specialist. Well, as you can gather, that's a total mouthful. So SAC-CNS for short. My job is very much aligned with the 4 pillars of advanced practice, which include clinical practice, leadership and management, education and research. So in my day-to-day role, I and my colleagues, we run our own tumour site clinics. I will have the opportunity to meet patients. I might be there to consent them for the chemotherapy or immunotherapy treatments. I'll also provide education about the side effects of what to expect with the treatments, but also, you know, how to hopefully combat this and operate sort of, you know, daily life and any other troubles or worries that they may have. Then I get to meet them along the way with regards to reviewing them in preparation for the cycles of treatment. If they're fit and well, then I can go ahead and prescribe, but if they're not so well, then it's down to me and the team to make the necessary decisions and make the next plan as to whether we delay the treatment or whether the person needs to be admitted, and make sure that everything's you know, teed up and in place. I also get to help support with the education of staff training in relation to SACT. This often requires me to present on study days or marking of workbooks or assessing staff in practice. Part of my role is a lot of management stuff as well, but also I'm on a few working groups for various topics across sort of the Wessex network. I've been asked why genomics is important in my role. And as we know, cancer is a disease of the genome. It occurs when changes in a person's genome result in the cells growing and dividing uncontrollably. These genomic variants can be inherited, which is your germline, from a parent, or they're acquired, which is your somatic, at some point during a person's lifetime. As oncologists are now receiving more genomic data with the advances of sequencing, this is enabling our consultants to identify which cancer drugs most patients may benefit from. So as part of my role, I am prescribing a range of these targeted treatments and immunotherapy and chemotherapy. So it's important for me to have an understanding of genomics and the advances of personalized medicine. This is one of the reasons why I signed up to the University of West of England's Genomic and Counselling Skills for Nurses and Healthcare Professionals module. I saw it advertised back in 2021 as a standalone online module, which was going to be funded by HEE. And with the landscape of cancer care drugs evolving, I was keen to be at the forefront of understanding what genomics is and how this impacts patients diagnosed with cancer. It's not something I recall learning when I trained, and I certainly needed upskilling. So module 1 back in sort of September, October of 2021 covered the fundamentals of genetics and genomics and what is genomics. It looked at ethical and legal considerations, and then taking and drawing of a genetic family, inheriting information, the 100,000 Genome Project. So it was full on and a whole new world of language to me. But what I particularly enjoyed was having the opportunity to be on a course with a range of healthcare professionals working in different fields all over England. The course assessments are very practical, which is much better suited to my educational needs. So for module 1, we were assigned into groups and we had to present a case study from practice. We also had to create a patient information leaflet. So mine, I focused on DPD, and I'm really proud to say that this is now a published leaflet that's used for patients at my place of work. And the great thing about the course at the time, it was just going to be a standalone module, but UE were able to find further funding because of the success of the module and turn it into an opportunity to study towards the PG cert. So I definitely, signed up with the support of work. So module 2 kind of focuses on providing attendees with more in-depth knowledge and skills to implement genomic healthcare in their day-to-day practice. We are shown how to develop communication skills and behaviours to facilitate conversation involving genomics with patients and families. And the assessment for this was to have a genomic discussion with a patient, write a letter to the patient explaining the condition, the inheritance pattern, the genetic test or result. And this letter had to include a visual aid, such as a picture or a diagram to help explain the relevant genomic concepts. And then as part of it, we had to then follow this up with a written reflection about our experience of the conversation. So that was tough. I do. It's not something that I do daily in my practice. So I really enjoyed the challenge and writing up a letter, and I found that element very very practical and a great way to learn. So I'm currently on module 3 at the moment, which is all about work-based learning. So the learning activities that I have to partake in involves engagement with professionals in practice, leadership and networking. So I have to find opportunities to across the region, or I've been lucky enough to attend various conferences that have taken place, and then I have to network and have conversations with genomics professionals, and then write this up in a reflective format. But what I'm really excited about is that with this year's module, 50% of the work is carrying out your own course and research. So I'm halfway through my own project, and you get to pick it relevant to your own needs. So my project is all about exploring if genomics added to the SAC study day is of educational value for oncology nurses, and whether this has an impact on their ability to understand how genomics can fit into the practice. Once our projects are completed, I think our deadline is about January time, we will have to present these at a conference next year. So I'm really enjoying the opportunity to undertake these modules, and I think it's brilliant, not only because it's really relevant to my role, but it's practical and has come with many opportunities for networking. So that's kind of all that I have to say, and I hope you enjoy the rest of your webinar. Thank you for listening.
Thanks, Kate. That was really good. It's really interesting reading the chat, because I can see I'm also doing this course, and I can see there's quite a few of you put your hand up saying that they're doing it as well, which is brilliant. And I think that's probably a good opportunity to mention the Genomic Education Programme, which is amongst the many questions that we're asking. We're not asking many questions, actually, small number of questions that we're asking in our surveys, because we're quite interested to know how many of you are aware of the Genomic Education Programme and the courses that are available out there for free, including up to a master's level. So it's certainly worth a look. So I can see we've got Laura's slides up next. So Laura, are you there? Are you ready? Here we go.
Yeah, I'm here. So can you hear me okay?
We can. I'll turn my mic off in a minute because I think the echo might be me. But just to introduce Laura, who's the diabetes specialist nurse, and she's going to talk to you today about monogenic diabetes. Thanks, Laura.
Thank you. So my name's Laura. I'm a diabetes specialist nurse under University Hospitals Birmingham, and I've just come to speak today about how genomics kind of fits into diabetes. This is something that I've become really passionate about in the last 12 months, and I hope that it can make other people passionate about genomics within their own areas. So next slide, please. So what is MODY? MODY stands for Maturity Onset Diabetes of the Young. So when we're looking at how genetics plays a part in diabetes, most of us have heard of type 1 diabetes and type 2 diabetes. So we know that patients with type 1 diabetes are insulin deficient, so they are not producing any insulin, and the treatment for that is insulin therapy. And we know that for type 2 diabetes, these patients are insulin resistant. So they have got resistance to the insulin that they are producing. And we target that with obviously diet, lifestyle, and also oral agents. So where does genetic diabetes fit within this? Well, it's a cause of diabetes characterised by the following. So it's normally young age onset, typically under the age of 25 years, but can be up to the age of 35 years and under. Because we're talking about genetics and it following gene pools, there is a parental history of diabetes. And often when you get speaking to these families, there's a really strong family history of diabetes. Absence of autoimmunity and persistent insulin secretion. So these patients are producing insulin, unlike patients with type 1 diabetes. And then there's that absence of obesity and insulin resistance. So they're not displaying metabolic features. So what is happening to these patients then? Well, these patients have got a monogenic cause of diabetes, which is causing beta cell dysfunction. So basically what that means is somewhere in their gene pool, something's happened which makes their pancreas not work as effectively as it can be. If we know which gene that is, we can then target the treatment to that gene. The next slide, please. So background, why I became passionate about monogenic diabetes. 80% of patients with a genetic form of diabetes get misdiagnosed as either having type 1 or type 2 diabetes. And research suggests that it will take on average 10 years delay from diagnosis for them to get the correct diagnosis. And actually in the work that we're now doing across the West Midlands, I would say it's a lot longer than that. I would say 20 years plus for some of these patients to get the correct diagnosis. If they're not being treated correctly, then they have impaired quality of life because the treatment that they're on is not appropriate. And also this can then lead to complications because they can't achieve optimal diabetes control because they're not on the appropriate treatment. And genetic diagnosis allows us to then personalise that treatment and screen family members, so we can cascade screen and predict who's going to go on to develop genetic diabetes and treat them earlier on in their disease process. Next slide, please. So my role, I had no prior knowledge of MODY. I just was looking after the young adult diabetes service at this time and became concerned about some of the young adults that were sitting in front of me about their diagnosis being incorrect. One sort of story that I tell people a lot that rang alarm bells with me is a young girl that came into clinic diagnosed with type 1 diabetes who hadn't taken any insulin for 2 years. And I looked at her and I thought to myself, you shouldn't be alive. Why are you sat in front of me? And that kind of raised alarm bells for me. And then I started asking questions. I started asking our consultants, what is going on here? Why have we not looked into this further? And we found that in the Midlands, we didn't have anybody doing genetic diabetes. So I completed the study day and along with a very supportive consultant, we set up a MODY service under UHB covering the West Midlands. So I am part of a genetic diabetes support network. I attend regular study days with them, and when I expressed interest in this, Exeter were funding the MODI course, so I was really fortunate to do that 2 days a week virtually. Next slide, please. So what do I do? So I now run genetic diabetes clinics once a week. In these clinics, I will see patients that are already diagnosed with genetic diabetes and look after them. I will triage new referrals into clinic through me. I will do a lot of phone call follow-ups because we're now covering the West Midlands region. Not everybody wants to travel to us. I would advise on medication changes, and this is a big one. So just last week, I took somebody off an insulin pump because she didn't need it. So she'd been wearing an insulin pump for a long time, and actually she did not have type 1 diabetes. So I took her off that pump, and she was so thrilled because she said she got her life back, but also her driving license back. Because she was having a lot of low blood glucose readings because she was on inappropriate treatment. I counsel families and I screen through families. So I draw a lot of family trees and go along the family line and cascade screen. And then I provide education and training to other colleagues within the diabetes network, but wider as well. Next slide, please. So why diagnose MODI? Well, like I say, we can change the treatment and we really can change these patients' lives. So MODI is often treated with a tablet called gliclazide, and we know that these patients are very sensitive to the effects of gliclazide, so it lowers their blood glucose levels quite effectively. So if you've been on insulin for a very, very long time and suddenly you're told that you don't need insulin anymore and your diabetes can be controlled with tablets, that's life-changing. But it's also cost-effective to the NHS. We spend a lot of money on insulin pumps, insulin therapy, and we're really changing the landscape of diabetes. If we can inform prognosis correctly, we can make sure that these patients are treated properly and that they don't go on to develop complications, which is really important. I think there might be one more. And it involves the whole family. So we're making sure that treatment is really personalised to that individual, and then we are caring for their whole family. And we've got a lot of patients at the moment who are thinking about having children and how this will affect their children. And so it really is involving everybody in the process. Next slide, please. So what have we achieved so far? So we were set a goal to confirm 8 cases of MODI within 100,000 population. So in 12 months into our clinic, we had 89 referrals, and we managed to actually diagnose 9 people out of those 89 patients with MODI. So we really surpassed our target. And this was life-changing for them because 7 of those 9 people changed from insulin to tablets, and 1 of them stopped all diabetes medication completely. So we sort of changed their direction of their diagnosis and the pathway that they are on. And actually, we've surpassed that 12-month mark, and we've had a lot more referrals in the past couple of months as we've been sort of doing these talks. And I'm pleased to say we've actually diagnosed another 3 people in the past 2 weeks. So that is the monogenic diabetes service. Does anyone have any questions for me?
One thing that I would like to say is the way that Laura's work all came about was she basically just showed massive interest in a talk that was given around monogenic diabetes, and I believe you went off very swiftly and came back with some patients that you thought, these seem to fit the bill, please help. So yeah, Laura has very much built a career basically from having seen the impact that this has. And I think that from my perspective, what I'm seeing with that is how all of our roles are changing and how we can actually start to build different roles within our own practice. So Laura, honestly, the work you're doing is absolutely amazing. And I think that you and the others should be really, really pleased and proud with yourselves. It's making a massive difference. Thank you.
Thank you.
You've got a question here, Laura, if that's
Yeah.
okay. Just asking for the age group of your patients.
So most patients with genetic diabetes are diagnosed under the age of 35. But what I say with that is, it doesn't mean that we won't accept a referral for an 80-year-old. We just want to know when they were diagnosed. So we're not discriminating, we're not ages. We just want to know when they received that diagnosis of diabetes. So we diagnosed a 70-year-old lady the other day who's had diabetes for over 60 years. And we've just told her that she's got genetic diabetes. So our age group is varied, but we're looking at the diagnosis being under the age of 35 years.
That's amazing, isn't it? Could you imagine getting to the age of 70 with that diagnosis and then being told, actually, there's a comment here, but I think it's quite accurate. It's just saying that I think trusts should all have a service like this, but I think it's probably fair to say that most trusts now have an understanding of monogenic diabetes, and hopefully they have somebody like Laura. We've got there are a range of champions, aren't there, across the region that you've probably got more understanding of than I do.
Yeah, and there is a whole network of people really interested. I mean, in the West Midlands, there is only us at the moment, but we're trying to get people interested. We're trying to spread the word because I think it's really exciting.
Yeah.
Can I just ask a question? Yeah. Laura, do you just need one blood test, and is there a consent form? What do you need to do to check? Do you send off a genetic test?
Yeah, so the patients that I triage, I will take bloods from, but initially I'll be screening them to see whether they are producing any of their own insulin. And then depending on the results of that, we then consent them for genetic testing if they meet lots of different criteria. So we have a criteria form, and if they meet that, then we will then consent them for genetic testing and send off a blood test, and it's two bottles.
There's another question here from Kafila asking if you're, well, I think I'm aware you are doing this, but how are you raising awareness out in the community?
So I have worked with the community diabetes teams, and we also fortnightly hold sort of webinars for GPs and practice nurses to try and increase awareness and encourage them to just chat with us, really, because that's how it started for me, is just asking those really, silly questions that seem silly, but it is, why has nobody looked at this? Why is my patient sat in front of me living when they haven't ordered insulin for a long time? So we're just encouraging those conversations out in the community, really.
And there's another question here. Can insulin testing and genetic testing be done although these patients are on treatment? So I think the question is, if you've got a patient who's on insulin, can you still do the testing? Does it affect the results?
No, not at all. So we measure something called C-peptide, and that is just a measure of how much of the person's own insulin they're producing. So even though there isn't a measure for how much endogenous insulin somebody's producing, we do know that we can measure C-peptide. So C-peptide is a chain that kind of links the insulin together, and I like to just explain it as a shell. So when you produce insulin, you're shedding these shells, and we can count how many shells you've got, basically. If you've got loads of shells, then you're probably type 2 diabetic because you're really insulin resistant, so your pancreas is working really hard. If you've got no shells, you've got type 1 diabetes. And if you're somewhere in the middle, that's where I want to know what's going on with you. So that is measuring their endogenous, so it doesn't pick up what they're injecting in that test.
Brilliant. Thanks, Laura. Any other questions or comments? Or we can and that's you're doing great work. Thank you.
Yeah, thank you for having me.
Pleasure. So our next speaker, unfortunately, which is Sarah Burrows, is unable to make the webinar today. So we have her apologies. So I just want to put in here, just going to put a little addition in here. One of the other things that's going on this week is that we have been out about in different trusts. We're going to be in UHB tomorrow morning with a stand, and we're partly raising money for Genes for Genes, which may be something that you've heard of. Genes for Genes is a charity which raises money to support families with children with rare diseases. So really good cause, and obviously links in very much to genomics and what we're doing. So I'm going to put that I'm overloading you at QR codes, so I do apologise, but I'm going to put one in the chat which is related to Genes to Genes if you would like to spare 50p or something. It's a Just Giving page, but no pressure. Thank you.
Just to let you know, Donna and Phil, Donna, the other Donna, has managed to join. She's been having problems getting on, so it's just to make you aware that she is available.
Oh, lovely.
Fantastic.
Shall we carry on with Donna? That's our next speaker. Yeah. And then we'll still have a bit of time then for questions. I've still got a couple of very hard questions up my sleeve if needed. So we'll see how we go. But Phil, do you want to introduce Donna? Is that okay?
So we've got Donna Cohen. Donna is the lead midwife for the genomics midwifery lead, in the nursing and midwifery genomics team. So very happy and pleased to welcome Donna. Donna, are you sharing your slides? Yeah.
Hi everyone. Yes, just going. Hi Donna. Hi Phil and Charlotte. I'm just about to make the magic work, hopefully. Oh, technology is not my thing, believe me, but let's see what happens.
Donna always says that. I worked with Donna at NHS England, and she does beautifully with technology, so she will make it. It will be fantastic.
Okay.
And sorry, just one more thing to just add. For the questions that are in the chat, if they haven't been answered, we will be sending them out to everybody and we'll get some answers out to you, or if you haven't had your question answered. Sorry, Donna.
Oh, that's okay. That's all right. I'm just, as I say, working the magic. Let's hope the magic works. Right. Let's see if I can get this up to you now. Bear with me. Is it up there?
Yeah.
Can you see it?
You're gonna put it in slideshow mode.
Okay. Can you see this now? Hopefully this will show up now.
Yep, can see it. Thanks, Donna.
Oh, fab. Great. Thank you. Thanks for confirming that. Isn't it always another thing when we use on Teams? Anyway, good morning, everyone. And thanks for the kind introduction, Phil. And thanks for inviting me to join Central and South's webinar. And this is the third time that I've spoken to Central and South, so I do feel very much at home and part of the team, even though I'm based nationally. Without a doubt, genomics is changing the way we look after the health of our mums and babies. And today we're going to dive into what genomics is, how it's being used, and how it could revolutionise healthcare during pregnancy and early life. And over the course of this very short presentation, you'll also hear about what's new on this exciting horizon. So I've got a few little additional things to add to this slide set. Okay, just a quick overview of what I'm going to cover: transgenerational genomics, genetics and genomics, mainstream and genomics and maternity care, and as I said, genomics, what's new on the horizon. Now, just a pause for thought. When Jennifer Worth was a community midwife, the author of Call the Midwife, it was around this time that the double helix, the twisted ladder structure of DNA that we've seen billions of times, was discovered by Watson and Crick, which, as you know, marked a milestone in the history of science and medicine and gave rise to modern molecular science, genomics as we know it today. And this little quote is taken from my book, which I've still got over here, May's Midwifery, from 1989, the 11th edition. where it says the pace of an advance in our understanding of inherited disease is rapid and accelerating. These advances are making a considerable impact on the practice of obstetrics and midwifery as elsewhere in clinical medicine. And now we're up to the 16th edition of May's Midwifery, and I was kindly invited to write the chapter on genetics and genomics. And honestly, the difference between the two chapters is so significant. So if you happen to see a new copy of May's Midwifery, please take a dive into chapter 16 and you'll see what's there. So what is genetics and genomics? And you've probably heard all this before, but there could be people on this webinar, you know, and it's new for them. So I've just put together this very hopefully simple slide to explain things. So our bodies are made up of millions of cells, and each cell has a copy of our genetic information in our DNA, which is stored in chromosomes. Changes in the DNA or chromosomes can cause genetic changes called variants, and we can do testing to look for these types of changes. So genomics is essentially the study of a person's entire genome, the 20 to 25,000 genes, and how they work and interact to influence the growth and development of the working body. Whereas genetics relates to the study of inheritance and is targeted at one or two genes associated with the condition. Whereas genomics looks at multiple genes using new technology called whole genome sequencing and the interplay of those genes and the variation or the changes, alterations, you know, between the little base pairs, which you can see on the lower right, as well as the interaction with environmental factors, which we know as epigenetics. So you've probably heard these terms banded around: variants, alteration, gene changes. We're talking about the same thing, and it can explain why, you know, these little changes can make a difference in a baby or a person, you know, an adult. You know, anything from a cardiac condition to skeletal dysplasia to a baby born with a metabolic condition or a rare form of diabetes, as we've heard, and the list goes on. And for midwifery, genomics has the potential to contribute to the government's maternity ambition, and that is to reduce stillbirth, neonatal death, maternal death, and brain injuries by 50% by 2025. So obviously using genomics is going to inevitably increase complexity and uncertainty about clinical meanings of results. However, it will make genetic diagnosis available to more people more quickly and cheaply and support specialities in doing genetic tests on a routine basis. And this is what we've already seen in maternity. And I'm going to just signpost you to this. Next slide. So in the middle is our NHS National Genomic Test Directory. And there's also an equivalent for cancer. But as you can see on the left, there's several genomic applications that we're already using in maternity services and perinatal healthcare. And all of these are cited within that big dossier of tests. So, for example, you know, the standard carrier type, which we've been using for years to look for trisomy in particular, that looks for missing or additional copies of the book. If we go back to this, we can see the book and we can see the chapter. So we're looking for missing or additional copies of chapters within that book. QFPCR is like a duplicated chapter. So we're looking for duplications of that chapter. The array, sometimes called SNP array or CGH array, is looking for missing or duplicated paragraphs or sentences. And rapid exome or whole exome sequencing or whole genome sequencing is looking for these very, very tiny spelling mistakes, as I said, on the far right, which counts for 3.2 billion bases. So, you know, it's like going into the centre of the earth or going in the middle of an onion. We started on the outside and now we're going, you know, for the deep dive. And there's around about 20 fecal genomic tests that are in that National Genomic Test Directory. The rapid prenatal whole exome sequencing, which is used for fetal anomaly, is called R21, and the rapid postnatal whole exome sequencing is called R14. And that came after the R21 and received quite a lot of press because it really is transformative for newborn babies in NICU and PICU and acutely unwell children. So moving on, transgenerational genomics. And what is this about? Well, transgenerational genomics is essentially looking at the life course, and from a midwifery perspective, we use our knowledge to identify and explain genetic risk all the time, and we advise and suggest on, genetic testing through screening to help families make an informed healthcare decision, and it really does enhance the health and well-being for mothers and babies. And as you can see, our involvement could be anything from preconception. There are midwives that work in reproductive medicine services for pre-implantation genetic processes. The most common area is prenatal, which includes antenatal care. And postnatal, as just mentioned, we've got newborn screening, the NHS newborn screening programme, but soon to come will be the generation study, which I'll explain a little bit more about. But also we need to think about NIPE, because of course, things can be identified through NIPE. And all of this really ties together with the NMC standards of proficiency, which highlights the need for midwives to be aware of genomics, particularly as we're becoming more mainstream. Midwives need to have a general and basic awareness of genetics and genomics to be able to talk to pregnant women. So in terms of mainstreaming genomics, what does mainstreaming mean? Well, what it means is actually bringing genomics, in the pathway to become a routine aspect of midwifery care. And, we've got golden opportunities here where we can have these genomic conversations. As you can see, in the NICE care pathway, we have, 9 touch points, and for pregnancies that require a little bit more, there's additional touch points. But it's not just about the antenatal period. Obviously, it goes and extends into the newborn period as well, the postnatal period. So as you can see, these little pregnant women at the bottom are holding red flags. And, it's our responsibility with our understanding of genomics and genetics to inform them, for them to make informed and well-balanced decisions. So at the booking appointment, we're gathering information, we're undertaking screening. We've done that for a long, long time now. So our understanding of genetics is pretty good. We talk about autosomal recessive inheritance and trisomy. And of course, we then move over to combined screening, which can come back with a higher chance. And the next step is NIPT. And NIPT is certainly entrenched in genomics as it uses new generation sequencing for analysis. The 18 to 20 week scan, of course, we've got the rapid whole exome sequencing service now. And anti-D prophylaxis and bloods at 28 weeks. If you think about rhesus antibodies, blood grouping, and anything to do in that context, it has got a genetic basis. And so all these golden opportunities are here. And just to add, we've had the Ockenden report, and there's further investigations going on in maternity services, but the immediate and essential actions that came out of Ockenden actually said that, we must revisit and we must reassess, and we must do those sense checks at all visits. And that certainly applies with genomics, in asking about, how you are, family history. Sometimes things come out when you least expect it, but could help a pregnant woman get a genetic genomic diagnosis. And then moving over to the generation study, this is a higher level pathway. The Newborn Genomes Programme hopefully will be launching the generation study at the end of the year, which aims to sequence the genomes of 100,000 babies in England. And this is just a very high level pathway to show what golden opportunities there are to harness genomics again. And there's going to be quite a lot of learning from the model that is here. Across services when this pilot is launched, and we'll be taking the lessons learned and at some point applying that into mainstream practice. So all of this information you can find on the Newborn Genomes Programme website. Now, just going back to the antenatal booking history, we are playing our part in this, there's no doubt. When we, meet and greet for the first time pregnant women, doing a booking consultation, but we probably don't realise that we're actually, doing a genomic screen. We're exploring family health history, we're looking at the woman's medical history, and what we're essentially doing is looking for triggers to genetic red flag questions or factors which may warrant a genetic referral or even a genetic test. So, for example, we ask about consanguinity, young deaths in the family, and so, as you can see, the list goes on here. And, by asking these questions, they may reveal an underlying genetic predisposition for a condition that the woman or her baby may have, or even perhaps a family member. So essentially, they're like a springboard. And it's important to say at this point that it may seem quite overwhelming looking at, these genomic red flag factors in terms of, how much time you have to carry out a booking consultation. It can vary from 30 minutes in one trust up to 2 hours in the next, but it's not impossible. And I think the golden rule here is don't just confine, the exploration of family health history to the booking appointment, stretch it out and keep revisiting, as Okudun said, along the high level antenatal care pathway. It's also important to have an understanding about what your local services look like, who's involved in those services, and who you can lean on to get some advice if you suspect a genomic red flag factor. It doesn't necessarily mean it's a genetic referral. Just talking to someone with that expertise in fetal medicine or clinical genetics, even the laboratory, could help you on your way. And there's obviously, you've got your specialist midwives who are more au fait than any midwives to understand a little bit more about this, because they are really entrenched in genomic services. And this is an area of work that the lead GMSA midwives, who are part of the Midwives in Genetics and Genomics group or network, are looking at the moment. So moving swiftly on, because I know time is of the essence, let's look at what's on the horizon. You may be familiar with this. It could be new to you, but aminoglycoside antibiotics such as gentamicin are used as first-line treatment for sepsis in neonates, and they can induce hearing loss. And this is because it's strongly associated with a genetic variant, and I'm going to spell it out there for you, the M.1555A to G. And it's reported that this variant is in about 1 in 500 people. Now, we do know that 1,250 babies in England and Wales are born with this subtle change in their genetic code. And this is because the variant allows the antibiotic to bind more strongly to the hair cells in the baby's ears where it becomes toxic. And these tiny hairs help convert sounds into electrical signals that are understood by the brain. And if they're damaged, it results in hearing loss. Now, if you were to do a traditional genotype assay, it'd take about 3 to 4 days to get a result back. And, you know, paediatricians are very keen to get antibiotics on board to treat sepsis. They need to be delivered in an hour. And this is the reason why the PALO study was developed in Manchester University by Professor Bill Newman. It used a point of care test called Gene Drive, which you can see on the left, a little handheld device in NICU, to try and test this process out to reduce the turnaround time. So it's essentially delivered by the bedside, and it can predict whether a baby is susceptible to gentamicin. So it's going to test for this this gene variant. And they did this by taking a buccal swab. Nurses in NICU would take a buccal swab from the baby and pop it into the Gene Drive, and they'd get a result in less than 30 minutes. And it proved really fruitful. They got great results from it, and it went to NICE for assessment. And it's now being recommended for use in the NHS to see how well it works in a range of hospitals and to see what impact it's going to have down the line before it gets final approval. So this is just absolutely marvellous, and I do know that Gene Drive is also being looked for other conditions and medications to expand. And just to say that this aminoglycoside issue isn't just restricted you know, to babies. Of course, adults get gentamicin as well. And I do remember a story from the Northwest where a gentleman who was very fond of his record collection. He was in his 40s. He loved his music, always playing records. Also had a motorbike, ended up in an awful collision, ended up practically near dead and was on ITU, and on his behalf his parents agreed to him having antibiotic therapy, and it was gentamicin. As a consequence of that, he did lose his hearing, and the impact of that for him was just absolutely awful. So, you know, a lot of these things can be transferable, but obviously, you know, that needs to go through a thorough commissioning review. So this is something that I came across which is really interesting and certainly related to midwives and pregnancy. Most women experience nausea and vomiting during pregnancy, and, you know, hyperemesis gravidarum can affect up to around 2% of pregnant women. So that the nausea and vomiting is so severe, it can lead to starvation, nutrient deficiency, and problems with fetal development. And it can be inherited, can be passed down through families. And, you know, some women have a reoccurrence of it in subsequent pregnancies. But sometimes it's been poorly understood and undertreated. And some women, it's so bad that they consider termination of pregnancy, and it makes them depressed. Now, a new study from a team of researchers at the Keck School of Medicine and the Hyperemesis Education and Research Foundation have discovered that there are variants in the GDF15 gene linked to hyperemesis gravidarum. And they're looking at developing tools to predict who might be at risk of developing it, so that, you know, the pregnant women can be informed that, you know, we know the situation that's ahead and put better management plans in place. The discovery hopes that clinicians will ultimately be able to provide timely prediction and diagnosis, and as I said, you know, better treatments for the underlying cause. And as I say, this condition is just absolutely awful for pregnant women. But in terms of babies, they're more likely to be small for gestational age compared to infants of healthy mothers. and also at a higher risk of tobacco, cocaine and amphetamine use in the future. And babies exposed to hyperemesis also face more developmental problems, including a higher risk for autism than their healthy counterparts. And finally, I thought it was worth mentioning about a new service that NHS England will soon introduce, which is a new genetic blood matching service for people with sickle cell disease and thalassemia, so that they get a better experience and reduce pain from side effects of having the transfusion. And although, you know, blood is currently matched by a blood group, there are differences within blood groups that can trigger immune responses to transfused cells. And about a fifth, 17% of patients get these side effects. So this is great news for individuals affected by sickle cell and thalassemia, and I'm sure the first of many other treatments to come for other conditions. So I just wanted to show you this slide. You'll be familiar with this. It's from Embrace UK. And we do know the facts are there that the risk of maternal death remains 4 times higher for Black women and 2 times higher for Asian and mixed ethnicity women than for white women. It's multifaceted and can contribute to the limiting, and genomics can contribute to the limiting the constellation of problems that I think are reported in Embrace. And I've highlighted some areas here where if we think genomics, you know, we can contribute our enhanced knowledge and competency in this area. So, for example, pre-pregnancy public health messaging around smoking, alcohol, healthy diet and obesity, which we're doing already. You know, we know that is also related to epigenetic changes. Pathways of care, designed to be able to flex, to put the woman in the right direction at the right time to the right person and place for treatment in terms of genetic red flag factors, as I mentioned earlier. And, you know, sometimes it's just about having that conversation with a colleague rather than having to actually refer a woman to a service. Recognising the abnormal, once again, through genetic red flag factors. And as I mentioned before, you know, we've got point of care tests as well for gentamicin. And obviously, there's other issues that we can also ask about regarding the pharmacogenomic side of things, you know, adverse reactions to codeine or morphine, pregnancy loss and previous abnormalities, and the list goes on. Risk is dynamic and should be reassessed. As I mentioned, in the mainstreaming pathway, there's ample opportunities to think about genomics in the pregnancy pathway, which just shouldn't be limited to the booking history. And providing postnatal care, a great opportunity, perhaps more time to talk with women in terms of newborn screening, which covers metabolic conditions, which are essentially autosomal recessive, and the generation study, which is going to bring more light into sequencing 100,000 babies' genomes. And of course, the physical examination can yield physical abnormalities, which may lead on to genomic testing. And one thing which I think is really key here is stop gatekeeping and collaborate with colleagues. And this really is a key message. Again, understanding your service, not working in isolation and expecting to be that genomic expert, because at the end of the day, we have a limited scope of practice in terms of what we can do, but referring on, learning from others, sharing and improving our knowledge and competence for the best interests for our women and babies, and working cohesively within an MDT environment. So just to summarise, I really like this quote from Steve Jobs. You cannot connect the dots going forward. You can only connect them going backwards. So you have the trust that the dots will somehow connect in your future. And, you know, my main takeaways are antenatal care brings with it a range of interactions that can predict or anticipate fetal problems and maternal problems. But the exponential emergence of new molecular technologies will become part of mainstream care. And I'm aware that midwives who work in non-tertiary level services may not be perhaps as au fait about genomics and what is available. But in time, this will change, and it'd be good to, you know who your key individuals, colleagues are at tertiary level, and, you know, learn from them and come to events like this to know more. Grow your network. Midwives can play a fundamental role, and there's fantastic opportunities to extend your knowledge through the NHS England Genomics Education Programme. And finally, just to say that, you know, the message that comes from this presentation and what you've heard today, it's not about imposing genomics upon you. It needs to be participatory, because you've got it, you've got the basis there already. It's just enhancing that knowledge and awareness, and obviously working in collaboration with your colleagues. And on that note, I hope I haven't run over time, Charlotte and colleagues. Thank you for listening. Thank you.
Thanks so much, Donna. Just out of interest, have we got any midwives out there? If anybody wants to put a show of hands, you may have put it in the survey, but just curious to see how many we've attracted, because obviously if we haven't, we need to attract some more. But thank you for listening. That was excellent. Thank you, Donna. Any questions? Oh, here we go. We have got some midwives. That's good to know.
And then
is Lydia,
yeah, I'm trying to work out if Lydia is now asking a question or whether she's just letting us know that she is a midwife.
I think she's just letting us know. And I think there's quite a few people starting to sign off, so maybe we should just give our thank yous for you all to spend these 2 hours with us. It's been a great morning. Really thankful to all of our speakers. It's been excellent. If there's any questions or anything on the back of this, we'll be sending, we've got all your emails, so we'll be sending out all the information and another little survey feedback, but mainly what we really want to know is what you need to know, what we can help you with, and these webinars are for you. So if there's anything in particular that you want included, and I can notice there's a little chat going on about pharmacogenomics, and luckily Hayley, our pharmacist, the GMSA pharmacist, is here and has been answering those, and that's something we are going to focus on in the next webinar, isn't it, Phil? So
we do have a hand up from Tasha, which is, I think, just gone up.
Oh, hi. No, I'm just listening in for North East Yorkshire. I was just wondering, Donna, if it's okay if I put your contacts to colleagues of mine in Sheffield and the North East of Yorkshire.
Of course,
that's great. Yeah. Nice to meet you, Tasha. And yeah, that's no problem at all. Yeah, happy with that. Thank you.
Thank you.
That's good, isn't it? Even though we work in one particular region, we're linked in obviously to all the other regions in England and in the other countries in the United Kingdom. So it's really good that we're collaborating and working together, which is what these webinars are about. Any final thoughts from anybody?
Just to say as well, we will be sharing the recording, but also a little certificate of attendance. But I've put up, and I hope you can see that there is lots of education out there that's available out there, and this is with thanks to Hayley, our pharmacist as well. This is her slide. So lots of education out there, which again will be included in the information. And then if you are still on the call, this is our QR code for some feedback, which we'd really appreciate. We get lots of learning from the feedback as well, and how to improve and get better webinars out to you all with information. But really, I think overall, it's just so that what the session we hope we got out of the set for you out of the session is how relevant genomics actually is for all of us. It is the first in a series. Our next one is in December. We will be sending out information about that soon. And that one is going to be more focused on really the basics of genomics, the technologies, the testing technologies, pharmacogenomics, so treatment, medication. And so hopefully we'll see lots of you there as well. But I hope that, and I hope you have got lots of out of today on the relevance of genomics. Charlotte, do you want to?
Sorry, I was just typing my email into the thing. Sorry. Yeah, thank you all very much for coming. It's been great to have so many questions asked of our speakers. I think it seems to have gone really quickly. I hadn't actually even noticed what the time was. Thank you very much to those that have organised it as well. And this is just the first in our series talks. We're looking at creating niche to normality in terms of genomics and genetics, because we want people to start seeing it as a normal part of your routine practice. So we will be moving on to doing different talks as well, and we'll also be doing more which are working alongside our colleagues at other GMSAs. Thank you very much.